Hi, everyone. Welcome to our second CanVector National Thrombosis Seminar of the year. So just a friendly reminder that these are monthly seminars that will be hosted live throughout the academic year, featuring state-of-the-art thrombosis and VTE lectures presented by both Canadian and international experts. The video recordings of the seminars will be available online at the link that you can see here. And another friendly reminder that these national seminars are a self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. So my name is Joseph Shaw. I'm a hematologist and thrombosis medicine specialist at the Ottawa Hospital. I'm the chair of the National Seminar Planning Committee, and you can see the other members of the Seminar Planning Committee here. So today's presentation is entitled The Winding Road to Personalized Antithrombotic Therapy, a Translational Perspective. Today's speaker is Dr. Hugo Tincate from Maastricht University. Dr. Tincate is an internist with a focus on clinical thrombosis and hemostasis. He is a professor of clinical thrombosis and hemostasis at the Cardiovascular Research Institute of Maastricht, also known as CARIM. An adjunct professor at the Center for Thrombosis and Hemostasis at Gutenberg Medical Center in Germany, and a fellow of the American Heart Association. His translational research program focuses on the mechanisms underlying thromboinflammation, specifically as it relates to both cardiovascular disease and atherothrombosis. And his recent translational research is focused on the pleiotropic actions of coagulation proteases in atherosclerosis, atherothrombosis, and ischemia reperfusion injury. His clinical research program is aimed at chronic thrombotic disease, including peripheral arterial disease, coronary artery disease, antithrombotic therapy, as well as venous thromboembolic disease and PTS. With an H-index of 107, he has published over 450 papers and has been cited over 44,000 times. So welcome, Dr. Tincate. We are so happy to have you as a speaker today for our national thrombosis seminars. I'll hand over to you in just 1 second, but just to go over the learning objectives here. So after this seminar, participants will be able to gain a better understanding of thrombosis mechanisms in vivo. They will be able to learn about specific blood biomarkers for activated coagulation, to discuss the rationale for specific interventions, such as inhibitors for factor XIa, and to exchange ideas about more personalized therapy management. And just a reminder, so we'll have this presentation today, but afterwards there's going to be a 15-minute Q&A period. At the end of the presentation, you can leave your questions. You can write out your questions, and then both myself and Dr. Tincate will be able to review them and discuss. So Dr. Tincate, I'll hand over to you. Thank you very much for presenting today.
Thank you very much, Joseph, for this kind introduction. And thank you, audience, for being available to listen to me. I much appreciate it. It's an honor for such a distinguished country and its scientists in this field of thrombosis and hemostasis. My voice is a bit rusty, so I apologize beforehand if I need to cough in between. It's a mild flu that's bothering, but I hope I will manage during the presentation. And this is indeed the title. But before I get into the topic, I wanted to share this information with you because I figured, well, I found out that it's 60 years ago that the original coagulation cascade, or what also was known as a waterfall concept, was published by different groups. Robert Macfarlane in the United Kingdom on the left-hand side in Nature, 1964, and two American scientists, Earl Davey and Oscar Rednoff in Science. And they were a little later, but that was not their fault because these were competing research groups, but they worked quite closely towards this final results. But the Americans had the disadvantage of a very obstructive reviewer who was quite a famous biochemist, and he didn't believe that the cascade existed at all. He felt that prothrombin and alpha-prothrombinase would be sufficient with a little factor V to drive thrombin and fibrin formation. But finally, he had to give in And the paper was published in Science for very good reasons, obviously. And it's interesting to see that at the time, the elements of the cascade were already known. It was known that there was phospholipids involved, cell surfaces, that calcium was important, and there was some uncertainty about the activators of factor 12, Hagemann factor. And the idea was that the cascade always started at that stage, but they also knew that there was tissue thromboplastin, that there was a potential other activator, and another pathway that we now recognize as the extrinsic pathway. So this is the original concept of the cascade, and in the decades to follow, the other details were, of course, further explored and characterized the kinetics of the prothrombinase and tenase complexes that you see in the lower left-hand panel of this slide. And the principle of the cascade is for hemostasis, of course, extremely important, because if we bleed, you need a rapid sealing of the wound within a couple of minutes, preferably. And the cascade, in concert with the vessel wall and platelets, can take care of that. So that this is a logical concept and finally explained. And in our country, Professor Koen Hemker was from about the same generation as a very young scientist at the time, and he spent time with Robert Macfarlane to further work on the prothrombin converting activity. And eventually, you probably all know that this further improved the concept of thrombin generation assay as a model for mimicking the coagulation cascade in vitro in a plasma-based system. And according to Hemker, the idea was that this would be the future electrocardiogram for coagulation, and that it would reflect everything basically about an individual's capacity to clot or to bleed. And the title is from Macfarlane, Science is Difficult, but People Are Impossible. And Hemker likes that very much. He's 90, but he's still active in this field. Now I want to switch to the presentation, in fact. And I'd like to start with this slide and this figure that was drawn up by my chairman, Joseph Shaw. And that's included in a paper that will be published shortly, as soon as I pay the bill. For this open access work. And I think it's I'm quite proud of this paper. I think that Joseph and Stefan Nopp and the other authors did a great job in formulating ways ahead to make some steps forward in biomarker research and to see whether blood biomarkers for coagulation and hemostasis can eventually be utilized for personalized medicine purposes. And what I will do today is focus on two of these elements, the mechanistic biomarkers in blue and the clinical disease biomarkers. And hopefully, and maybe also during the discussion, if there is time, we can think a bit about how to translate those biomarkers towards guiding and supporting antithrombotic therapy. So my presentation falls in two elements. The first part is the past, where I will discuss the example of sepsis and LPS-induced thromboinflammation as a model for mechanism of thrombosis, and to tell you how biomarkers have helped us to understand the actual mechanisms in vivo. And the second part will include biomarkers in relation to clinical disease. So if you're looking for a cascade and a pathologic cascade, so not so much the involvement in hemostasis to arrest bleeding, but in thrombosis, well, a very dramatic example is sepsis-associated coagulopathy. And the picture is from Fletcher Taylor, who did a lot of primate studies using live E. coli infusions, which dose-dependently induced a quite dramatic coagulopathy. And you see in the figures, if you take the black lines, that is the lethal model, that gives quite dramatic and rapid changes in coagulation biomarkers as indicated, with prolongation of clotting times, with depletion of fibrinogen, a sharp rise in fibrin degradation products, thrombocytopenia, and everything. So this is a pathologic cascade within, well, minutes or a few hours, causes a dramatic DIC, disseminated intravascular coagulation. At the time when I was a young resident in Amsterdam, I had in the neighboring institute Professor Erik Hack, who was an immunologist working there, and a research fellow, Walter Meerman, who came over from Switzerland, from Bernard Lemler's group, to join us. And we were interested in contact activation. We felt the original model of the coagulation cascade starting with factor 12. We didn't know much about the agonists, but we felt that we should pursue it in a dramatic model of disease, which was in this case in children with meningococcal septic shock. And he had this panel of assays available for contact activation markers, including protein levels such as factor 12 antigen, but also activated factor 12A in combination in complex with one of the key inhibitors, C1 inhibitor. So the principle of these enzyme inhibitor complexes is that you detect the fraction of enzyme that is inactivated at the moment. So it gives you a time point, a picture, so to say, of the actual condition of coagulation at that moment. And what we observed, and we focus in this slide, I would like to focus for time also on factor 12. You see that in 6 of these 13 children, there was detectable factor 12 activation ongoing, but the normal values are not that much lower. In other words, the levels of factor 12A were not dramatically elevated. And you do see also for the other markers, and on the right-hand side, thrombin and antithrombin complexes, they were clearly elevated. So there was a lot of clotting going on, but whether the contribution of factor 12 to this coagulopathy was visible or not, we weren't so sure. There was a modest correlation between factor 12 antigen and enzyme inhibitor complexes, but this is only circumstantial evidence. And we also knew from a few years earlier from the studies, the primate studies again from Bob Coleman and Fletcher Taylor, that if you, in a lethal model of bacteremia in these animals, you co-infuse a monoclonal anti-factor 12 antibody that blocks contact activation, you see that it will reduce the conversion of kininogen, it will stop the generation of kallikrein, again measured with this enzyme inhibitor complex, it will attenuate the decline in blood pressure, but it will not have any impact. It did not have any impact on the coagulopathy in terms of reduction in fibrinogen, factor 5, and platelets. So apparently, the coagulation was not so much driven by factor 12, whereas the inflammatory effects were attenuated by blocking factor 12. And this led us to another pathway to look at the involvement of the tissue factor route that had been characterized, of course, in the meantime, and using a milder model in which we could also use human volunteers or make use of human volunteers by infusing them a small quantity of endotoxin, which is the pathogenic component from gram-negative bacteria. And you see if you infuse endotoxin on the left-hand side, it will induce a rise in thrombin and antithrombin complexes that can be blocked almost completely by a co-infusion of an antibody against factor 7A. And other studies, similar studies, endotoxin infusion studies in volunteers from Bernd Yilmaz's group also confirmed that this was tissue factor 7A that was the main driver for coagulation and coagulopathy after endotoxin infusion, associated with an increase in the middle images in tissue factor expression in monocytes, and on the right-hand side with an increase in clotting activity. And this is also visualized in this figure. It was taken from another publication in which Monique Minema, who was a PhD student at the time, and she's now a professor in hematology in Utrecht, and she studied the kinetics of this coagulation activation process after tissue factor after endotoxin infusion, and could show that this led to a marked increase over time in prothrombin activation in thrombin and antithrombin complexes, with a peak at 4 hours. And this is quite interesting. So you see an initial jump in thrombin formation and a more protracted production ongoing with a peak at 4 hours and a gradual decline. We don't know all the intermediate points, but it may take a while due to ongoing tissue factor exposure or microvesicles from monocytes. This coagulation process may go on for quite a while. And interestingly, what we also, because we were curious about whether also factor 11 activation would be measurable, because we were still, looking with with one eye, with one keen eye to what the contact system would do. And meanwhile, we had also information from George Brose's group and others that thrombin would be an important feedback activator of factor 11. So we assumed that although factor 12 may not be so important in this situation, factor 11 may still be activated by the feedback activity of thrombin. So that is what you probably see here. At least for sure you see factor 11 activation. This is free factor 11A with an enzyme capture assay detected. And this is followed by factor 11A in complex with inhibitors and this is in a model. This is visualized in the left lower panel. So thrombin generation, it takes a while to develop. It's associated with factor 11 activation over time. And this process indeed may be dependent on the feedback activity of thrombin. And that was nicely shown in similar experiments from Bernd Yilmaz's group, who co-infused hirudin, the specific thrombin inhibitor, and could show that the procoagulant actions of endotoxin were blunted at least by the co-infusion of thrombin inhibitor hirudin. It did not have any impact on the fibrinolytic activity, as you see, but that's not for this presentation. So if I summarized the main findings from this model, and this is, I think, I like these data because it gives you a good idea of the mechanisms under in vivo conditions that are ongoing, and it learns us about, that factor 12 is, not a major driver, at least in sepsis and endotoxemia of coagulation, that it's more important probably in the direction of inflammation. The tissue factor 7A is the main driver, that the cascade develops, but not within minutes, but within several hours. We identified several sequential steps in the procoagulant processes and also fibrinolytic pathways that I will not get into. We demonstrate thrombin's impact on the intrinsic activation. And when we infused factor 11A, in a distinct experiment, not involving endotoxin infusion, we could also estimate the kinetics of these complexes over time. So it gives us a good idea of the kinetics of this coagulation process. And what I also think is interesting, if you think about this in terms of a delayed or a protracted process, it gives also time for these enzymes to do other things than just make fibrin. And I think this creates openings also for ideas about how enzymes like factor 11A or 10A or thrombin may interact with endothelial cells, for instance, with receptors. There are a lot of mechanisms that may be driven or influenced at least by these proteases. And this is a figure from a proteomics analysis from our colleagues in Mainz that show that 11A may have several distinctly different interactions with systems beyond coagulation. And I mentioned here on the left-hand side a few very important publications that get into the details of some of these pleiotropic actions of factor 11 in relation to angiotensin and blood pressure regulation in the heart, the Science Translational Medicine paper, and most recently Owen McCarthy's group in blood on the impact of factor 11A on endothelial cell integrity. So I think taken together, we can learn a lot from biomarkers in terms of understanding mechanisms. And it also is inspiring because it creates opportunities to think how these enzymes may interact with other systems. There is time. It's not a process of minutes. It takes several hours. These enzymes can do all kinds of things beyond fibrin formation. At least that's my imagination, and perhaps you disagree, but we need some imagination in order to to go further. So in the second part, I'd like to shift a little bit towards clinical conditions and discuss biomarkers in relation to thrombosis and thrombotic mechanisms in venous thromboembolism, acute coronary syndrome, which I will not discuss, but stroke I will focus on a little bit more. So, and then I want to continue focusing on factor 11 because it's still a hot topic. It's still an important target potentially, and there's been a lot of debate about it recently. And this is from April, not so long ago, in the Wall Street Journal, that the new blood thinners were, well, identified, targeted at factor 11, that will prevent blood clots. But in the second line, it says that could prevent clots, so there was a little uncertainty about the efficacy. But anyway, it was very much a hot topic for the pharmaceutical industry and thus for the investors in the industry. And let's see where it will take us and how biomarkers can be useful in further identifying patients that may have benefit from factor 11A inhibitors or from other specific targeted drugs. Now, what was the rationale? And you probably all know this, so let me go over this quickly. Factor 11 deficiency is not associated with spontaneous bleeding, although it's a bleeding diathesis known as hemophilia C. And observational and genetic studies show associations between factor 11 level and the risk of venous thromboembolism and ischemic stroke, and lesser so to myocardial infarction, ACS. Preclinical studies show potential to prevent thrombosis, and clinical studies also indicate proof of principle that it works, that you can, when you target factor 11, you can prevent thrombosis in specific models, and the price of bleeding may be less. So that's the idea about how to turn a disease into a therapeutic target. Now, you probably also all know this study that was published already, well, almost 10 years ago, that provided proof of principle that genetically lowering the level of factor 11 protein in blood down to levels of about 10% at the highest concentration that was used, the highest dose of this antisense reagent, that indeed led to a reduction in post-operative venous thrombosis. And I have summarized the data together with a few other compounds that were used in the model of knee replacement surgery that has been commonly used in thrombosis studies to study new anticoagulants. In comparison, the new anticoagulants with the standard therapy, which is low molecular weight heparin and enoxaparin postoperatively. And the summary of these data for the different compounds, this is the genetic compound that I just showed you. There are two monoclonal antibodies included here and a small molecule inhibitor, milvexian. And for all these compounds, you see that there was a gain in efficacy as compared to low molecular weight heparin at a modest price of postoperative bleeding. So this is good news, and it basically provides proof of principle that targeting factor 11 helps to prevent postoperative thrombosis in this particular model. So let's see if our biomarkers can provide some additional evidence for the role of factor 11 in venous thromboembolism, and not so much in the surgical department, but in all comers. In this case, study done by our colleagues in Mainz, patients with acute venous thromboembolism that were seen, and in the acute phase, blood was collected, and we studied, amongst others, factor 11A in enzyme inhibitor complexes, and these data indicate that these complexes indeed were associated with an increased risk of recurrent venous thromboembolism in these patients, depending on the magnitude of the enzyme inhibitor complex in the circulation at the time. So a blood sample taken in the acute phase, 11A complex is predictive for recurrent venous thromboembolism. Another potentially very interesting group are patients with cancer-associated thrombosis. And these are patients that were studied by our colleagues in Amsterdam, in patients from Paolo Simeoni in Italy. And the assays, and these are similar or almost identical assays that the ones we did, but done by Nigel Key in his laboratory, showing also for some of these markers like kallikrein and factor 11A, increments in concentrations as compared to healthy controls, but also, and importantly, that these 11A inhibitor complexes were predictive for incident thrombosis in these patients, comparably to, for instance, the predictive value of D-dimer complexes as indicated. That's not surprising, but also 11A apparently here associated with incident thrombosis. And similar data were found in a totally different study, also for patients, in this case with lung cancer in Italy, from Anna Falanga and her team, Patricia Gomez, the PhD student that addressed in these patients, also looking at the relation with incident venous thromboembolism and mortality, and also observing that for the 11A inhibitor complexes, like for F1/2 and thrombin antithrombin, there was a certain predictive power for incident thrombosis. And it's not so much about the diagnostic potency of these assays, because clearly markers like TAT or maybe D-dimer may be more practical, more convenient in this population. But this is about linking a specific coagulation protein to that outcome of venous thromboembolism. So I think altogether, these data strengthen the case that factor 11 is linked to venous thromboembolism, not only postoperatively, but also in all comers with venous thromboembolic disease and with patients with two types of different malignancy. So I think in that sense, are these biomarkers helpful in strengthening the case also for pursuing studies with factor 11 targeted therapies in different directions, and maybe also in patients that are more vulnerable for bleeding complications. Now, the situation may be a little more complicated in arterial thrombotic disease. And I'd like to focus in this case on stroke, ischemic stroke, and I start with discussing secondary prevention after ischemic stroke. And that's an interesting setting. What do we know about factor 11 if we continue on this pathway about factor 11? We know from genetic studies that factor 11 levels, as determined in part by SNPs in the factor 11 gene, are associated with an increased risk of ischemic stroke, not so much for myocardial infarction. And we know from a large study published in Nature by two different diagnostic techniques that both factor 11 and kallikrein are also linked to ischemic stroke, mostly for cardioembolic stroke more than for atherothrombotic stroke. At least that's what the suggestion was from this analysis. We also know from previous literature that protein levels of factor 11, increased levels are associated not only with venous thrombosis, but also with ischemic stroke, and lower levels with a reduced risk. So this also seems pretty consistent for myocardial infarction. As I said before, the data are at least not consistent and maybe controversial. We also studied the enzyme inhibitor complexes a while ago, pretty old studies, in fact, with the Leiden colleagues, Frits Roosendaal, Bob Siegering as first author. This is a case control study that was done in young women with stroke, in which the impact of oral contraceptives was studied, basically. We also looked at elements of the contact activation system and observed that there were significant associations for these patients with ischemic stroke and not so much for myocardial infarction. So again, this seems to be consistent with the prior data, but this is in young individuals. In a totally different population, these were patients from the Northwick Park Heart Study in the United Kingdom with the late George Miller as primary investigator, and he studied males mostly at risk of cardiovascular disease. So these were subjects that did not yet have suffered from a major thrombotic complication, but were at risk for thrombotic complications. And here, so if I only focus on the conclusion of this particular, of the abstract of this publication, there was also an association between the contact system, so to say, factor 12A, a bit more than other factors, with the risk of stroke in middle-aged men. However, the direction of the effect was the other way around. There was an inverse association for these complexes with stroke, in contrast to the data in young women. So apparently, although this factor 12, factor 11 system, so to say, was linked to the same complication, ischemic stroke, the direction of the effects was different in young women as compared to elderly males. And that's not unlikely, but of course, we have no explanation yet for the difference in the direction of these effects. But it may strengthen the idea that factor 11 plays a role in stroke, maybe factor 12 as well. So if you want to look further into it, you may wonder, okay, if we take the focus, if we put the focus on secondary prevention in patients with ischemic stroke, what can we learn? Because stroke is a complex situation. There is an acute moment, the acute thromboembolic or thrombotic occlusion, and there is the subsequent period of ischemia reperfusion injury, and of course the risk of recurrent stroke after the first episode. And recurrent stroke is the primary focus of the studies that are ongoing or have been done with factor 11A inhibitors. And this is the pipeline of the different products here for cardiovascular disease. So here I mean with arterial cardiovascular disease, different drugs, different classes of drugs, and there are more to come. And there will be a more impactful paper in Nature Cardiology Reviews pretty soon by others that nicely point out the different indications, the different products that are being tested. I want to show you two examples of phase 2 studies that were done with factor 11A inhibition, in this case with asundexian, after acute stroke. So this drug is then given on top of dual antiplatelet therapy. So these are patients coming in with atherothrombotic stroke. At least there is no suspicion of atrial fibrillation, because then they might have been on anticoagulation, or they should have been put on anticoagulation. So these are patients coming in with acute stroke, and then they will receive dual antiplatelet therapy for a period of about 21 days. And the idea was, if we apply on top of that factor 11A inhibition, it may provide further benefit in terms of efficacy gain. Here you see, meanwhile, in this busy table, that for the primary and secondary efficacy outcomes, there was no detectable signal of efficacy. But this is a phase 2 study, of course. Only in the post-hoc exploratory outcomes, there was an indication of possible protection against recurrent TIA or stroke. The other phase 2 study that was done was what's the axiomatic study with milvexian. That's the other small molecule inhibitor that also tested different doses of this drug, and the same result basically, or comparable lack of a signal in gain in efficacy. However, in contrast to asundexian, which did not enhance bleeding complications, you could see, well, that there might be a slight increase here at the highest doses of this drug in terms of an increase in major bleeding complications. But the numbers are quite small, of course, so there's no reason to conclude from this study that it would impose harm, but gain in efficacy is not yet visible. Now, stroke, as I said, is a very complex disorder, so it makes sense to approach it from different angles, and for that purpose, there are different classes of biomarkers. These are all the hemostasis biomarkers that have been tested over time by many others, inflammatory biomarkers, but I want to focus on one of the more interesting ones for neuronal damage, because it's like with the heart, where we test for troponin and BNP and creatine kinase, of course. For the brain, we could also take a similar approach. And for me, at least, as a non-neurologist, these data were quite intriguing, because what is shown here in this study, which is a compilation of data from a population with large artery ischemic stroke, showing that this particular marker, neurofilament light, which is a reflecting neuronal damage, shows, well, an elevated level at baseline at presentation of the patient, but it's continuing to increase over time, peaking at only at 14 days after the acute stroke. I find this quite striking that this ischemia reperfusion injury takes several weeks to develop. So you can imagine if you imply an anticoagulant on top of antiplatelets, that you also should be interested to know what is going on here in this period. And to get back to the biomarkers and to our favorite biomarkers for factor 11 and factor 12, well, we tested a whole bunch of them in this study that we did with our colleagues, neurologists in the Netherlands, in the Contrast Consortium, where they see patients presenting with acute stroke and with different types of management, endovascular thrombectomy in this case, plus or minus thrombolysis. That was the focus of this study. But if you look at the biomarkers in these patients, you see that there is not so much happening in time when we compare baseline 1 hour after thrombectomy, 24 hours after thrombectomy. There's not so much going on in terms of coagulation changes, only for the more central localized proteases, 10A and thrombin, you see some change here. But more importantly, none of these enzyme inhibitor complexes were significantly associated with the outcomes measures, which were final infarct volume and modified ranking scale after 3 months. So apparently no clear-cut associations for clotting and outcomes. In contrast, because you can say, okay, so what? I mean, biomarkers may have a limited sensitivity, but other biomarkers that we also tested in the patients included in another study but also from the same consortium, showed that if you look at markers of platelet activation or endothelial activation or both, or inflammation like fibrinogen and factor VIII, that all of these were associated with one of the other outcomes of stroke severity, final infarct size, or poor functional or long-term functional outcome. So apparently other biomarkers were linked to outcomes after stroke. And this is interesting because it leads us back to the preclinical data, and this is a very nice and comprehensive paper from Bernd Nieswand and Stoll from Würzburg that summarized the data from their animal models for ischemic stroke, showing that indeed platelets are quite pivotal in the acute setting and in the subacute setting where thromboinflammation is taking place. And these platelets interact with T cells to drive thromboinflammatory neuronal damage in a process that does not require rethrombosis. So it's not so much in these animals about preventing fibrin formation, but it's about how to attenuate these processes that are linked to GP1B and GP6. And in particular, GP6 may be an important switch molecule because it is a determinant of ongoing platelet activation and platelet release, also of polyphosphates that may activate factor 12 that may be a driver of inflammatory processes mediated by kallikrein. And it may link, of course, to coagulation. So GP6 may be quite pivotal in the setting of ischemia reperfusion injury. And that has been demonstrated or is at least tested in clinical studies where the focus is on targeting GP6. So now we move from a clotting protease to a platelet protease, and biomarkers indeed helped us to indicate that this route may be feasible and more important perhaps for patients with ischemic stroke. And GP6 is an interesting target because it combines antithrombotic and anti-inflammatory activities with also a low bleeding risk. And that was shown in phase 2 study that was published earlier this year with the monoclonal antibody directed against GP6, glanzosumab, showing 2 quite spectacular outcomes. That is an improvement in functional recovery, but also an improvement in survival after ischemic stroke. Now, this didn't hold in the subsequent phase 2/3 study that was done, the ActiSafe study, where none of these primary and secondary outcomes were favorably influenced, although there was a trend for a better functional outcome. And maybe this is due to the larger heterogeneity of these stroke patients, this stroke population. So we don't have any definitive answers yet, but I think also using these biomarkers, we may be able to further improve the selection of patients in the future for such therapy. So if you wrap up now what we know, not much about GP6, but about factor 11A in acute stroke. The preclinical experiments indicate that, well, factor 12 may be involved contact system, but GP6 may be an important molecular switch between platelets, inflammation, and the contact system. That the typical thrombosis prevention actions of factor 11A may be less important, except for younger individuals, probably with less atherosclerosis, and that the interaction of these key players may determine functional outcome eventually in patients with ischemic stroke. Now, the final few slides, if time allows, are on the primary prevention of stroke, and I will be really quickly, I will not go through the phase 2 studies, but we'll go straight to the phase 3 study that you are all aware of, asundexian versus apixaban in patients with atrial fibrillation. And this study had to be stopped because of inferiority of the 11A inhibitor against apixaban. And this immediately gave rise to these rapid commentaries, the oceanic fall of asundexian, and have we come to the end of the road for factor 11A inhibitors? And of course, this is discouraging industry and investors. And that's a pity, really, that negative studies would have such an impact, because it would kill a potentially interesting avenue of research and clinical application of such novel anticoagulants. The authors go through several possible explanations that they mention in the article. They mention escape mechanisms. They mention the possibility of too low dosing, because the 50 milligram dose of asundexian may have been a bit lowish in retrospect. At least there is some evidence that I will show you, and there may be changes in the background stroke population, and perhaps factor 11, well, may turn out not to be so important in this context. What about escape mechanisms? And then I come back to thrombin generation as a tool to help us here and to show the potential routes that may be affected by this 11A inhibitor, showing that if you stimulate thrombin generation by factor 12 activation, you get a very nice dose-dependent decline in thrombin generation by asundexian, and the same at low tissue factor concentrations. But if you use a higher concentration of tissue factor, for instance, 5 picomoles, you see that there is not much effect on the thrombin generation curve of the similar concentrations of asundexian. So that may be one biochemical escape mechanism. And I know this is not what the authors alluded to or pointed at, but I think the biochemistry may be more important in this case. And another escape mechanisms may be that if clotting would be started by factor 12 activation, that it does not solely depend on factor 11 to mediate procoagulant effects, if there are via factor 12, but also the kallikrein loop may bypass factor 11 to directly activate factor 9. So this is another potential mechanism. This worked here, and this was demonstrated by Henry Sprocida group and published. This works in the absence of factor 11, but maybe with inhibited factor 11 or at lower levels of factor 11, this may also become operational. And this escape mechanism was also nicely demonstrated and clearly with a clear biochemical basis published by Helen Philippou and her colleagues in the United Kingdom. And this is the pathway that bypasses factor 11. So there may be biochemical escape mechanisms indeed. The discussion on the doses of asundexian is intriguing, and this was rapidly published after the trial was published by our colleagues in Belgium, in Namur, showing that if you compare asundexian and milvexian, versus the DOAC they were tested against. Sorry for this. You see that asundexian only had a mild impact on the thrombin generation in their conditions, which are slightly different than from Dr. Heitmeyer in the previous slide. For milvexian, you see a more impactful inhibition of thrombin generation. And in fact, this looks more like what we see with apixaban. So it seems that this inhibitor may be either more powerful, more potent as an 11A inhibitor, or perhaps at higher concentrations shows some non-specific inhibition of the coagulation system. And finally, there is, of course, the possibility that in the complexity of thrombogenesis, factor 11 is not that dramatically important after all. And this is my final slide, ladies and gentlemen, because I promised you initially to say, to speak about personalized antithrombotic management. And I'm sorry, because I only hope to have paved the way towards personalized medicine by showing you that biomarkers may be useful, potentially also in phenotyping our patients, in characterizing pathologies, to better understand, on the one hand, the inter-individual variation, but also the relative contributions of different mechanistic pathways like factor 11 and GP6. And the challenge will be to make proper use of the observational data from biomarkers under steady state conditions or in acute thrombotic disease or during the process of ischemia reperfusion, to interpret that in a way that we can understand what is happening in the individual patient, and to see if we can better stratify patients with a certain type of thrombosis for specific anticoagulants that inhibit factor 12A or kallikrein or 11A, or for platelet inhibitors at the other end of the spectrum. I think both types of biomarker observations, both in the acute and chronic phase, may be relevant. And the goal would be, at least my long-term objective might be, if I would live long enough, to look at the combination of such biomarkers and capacity assays like thrombin generation or viscoelasticity testing to see or to inform antithrombotic management for the future. And I end with this beautiful figure that the chairman was so kind to draw for the paper that will come out pretty soon. And that shows the timelines we are working with, because we shouldn't forget that it takes decades of research, not only to develop drugs, but also to develop biomarkers that are suitable for clinical implementation. And the longest timeline is here for the antiphospholipid antibodies, but you see also for F1/2, for instance, or thrombin generation, it takes 50 years or more to develop this to a decent standardized methodology. This could make you pessimistic, but I think it's a sign of optimism that we still have a few decades ahead of us in which we can further make use of these biomarkers to improve and work towards personalized medicine. I owe much credit to my former mentor in Boston, the late Robert Daniel Rosenberg. He was a brilliant guy in terms of thinking about these biomarkers and the pre-thrombotic state. And with that, I'd like to thank you very much for your attention. And I'd like to acknowledge the help of colleagues in the past and in the present in the collaborations, and the people that I met at the ISTH last year and that came together to work on well, a very appealing article that I hope you will read pretty soon. So thank you with that. And if there is time left, I'm happy to address some questions.
Thank you very much, Dr. Tinkate, for that really great presentation. Really great tour just from basic coagulation and then to the 11 inhibitors, like you mentioned, in terms of their recent attempted clinical applications. So there's one question here from Dr. Weitz that I will get to. I did want to maybe start with one question of my own that I've been curious about and that we've discussed before. But in terms of these escape mechanisms, it's interesting to see the differences between in vitro and in vivo. And you talked a bit about this potential for tissue factor escape. Do you think that that factor 11 inhibitors maybe should be used for all these indications, or that maybe we might end up with more targeted applications? Like, for example, if you end up having malignancy, we know that tissue factor is a very, very important trigger for coagulation in that setting. And so do you think that there's no way to know for sure, but do you think that factor 11 inhibitors will be used for many different disorders, or maybe we might end up using them for specific, maybe prophylactic indications, and still be relying on our other coagulation inhibitors that target factors that are more central to the coagulation cascade?
I think so, that we should focus more on targeted populations for which there is a good basis of evidence that it will be helpful. And I pointed out that, in my opinion, at least, venous thromboembolism in association with malignancy or not is a very suitable region or area to focus on. But I understand also from the pharmaceutical industry's perspective that is not the major population in terms of the volume of patients, and that's probably a good reason why they also wanted to immediately go for atrial fibrillation or stroke or acute coronary syndrome. But we have to realize that arterial thrombosis as such is much more complicated, I think, in terms of the contribution of the coagulation cascade, so to say, in thrombosis, and it's more dependent on the vessel wall, vessel properties, on platelets, on other cells, microvesicles, etc. And particularly the vessel wall interactions may change over time, as I pointed out also, and that may be one of the main differences between the young population, like the young women with stroke, versus the older males that have been smoking and have a worse lifestyle and that develop stroke. These are not identical strokes in identical or comparable persons. These are different mechanisms that occur. For venous thromboembolism, the contribution of hypercoagulability is more straightforward. We know that their direct oral anticoagulants and vitamin K antagonists work, that they prevent thrombosis. And there we can think of optimizing therapy by using these 11A inhibitors, go for lower risk of bleeding in high risk for bleeding populations. And these are patients with malignancy, with renal insufficiency, with hemodialysis, and there may be a few other categories. So that's what I would focus on if it was up to me, which it isn't. I'm interested in arterial indications, but I think that requires much more of this characterization and understanding of the complexity of the processes before we could identify the ideal patients for these types of anticoagulants.
Yes, yeah. And I do think that you partly answered Dr. Weitz's question here, but he did say, based on your disease biomarker data, in which of the phase 3 indications do you expect success of factor 11 inhibitors? So, among those that you presented today, cancer-associated thrombosis, atrial fibrillation, ACS, or stroke, do you think that, based on the research that you've done, that there might be one of these that factor 11 inhibitors are more likely to be successful with for one reason or another, or we'll just have to wait and see for the clinical data to come out and show us?
Yeah, it's still difficult to say. Well, my idea was that, for instance, acute coronary syndrome would not be a proper indication because there is a weak basis of evidence from genetic studies, from epidemiological studies, from biomarker data that is not very consistent, pointing at factor 11, for instance, as a key player. We do know, of course, that in patients with chronic coronary artery disease, like in patients with peripheral artery disease, the addition of a direct anticoagulant like rivaroxaban that was tested in the COMPASS study in conjunction with aspirin had added benefit. So an anticoagulant as such may add something to the efficacy, in patients with coronary artery disease. But for the acute coronary syndrome, that may not be the appropriate timing. Maybe for secondary prevention, there may be something, but the underlying evidence is not as strong as for venous thromboembolism. For atrial fibrillation, we really don't know. And there we also lack good animal models. That's also a problem. We don't have good preclinical models that can help us in deciding on whether prevention of stroke, cardioembolic stroke in AF can be accomplished with inhibitors of the contact pathway or factor 11. And stroke is intriguing, but it's still complex. So it's hard. If I would bet, yeah, it's hard to say which indication. For the time being, I would focus on all venous thromboembolic disease indications that are quite appealing, and hopefully we'll be able to better study also, well, materials that are available, perhaps from these large studies with the 11A inhibitors in the arterial indications, to learn a bit more about differences in biomarker levels, be it GP6 or be it factor 11, whatever, to better figure out which mechanisms are operational.
Perfect. And we might have time for one more question. This is maybe more forward-looking question related to your last slide about biomarker discovery and then implementation and then using those findings for clinical research. But I'm wondering, I mean, do you think there's so much about biomarker research that is complex, right? And when we're trying to establish disease associations or discover biomarkers, it's all very unidimensional. We're usually looking at single associations, but these are, complex biological systems. There's a lot of interactions with all of these factors. And maybe that underlies some of these reasons why we develop drug targets and then we get to clinical trials and then things don't work out. Do you think that we'll get better over time in terms of getting to this goal of personalized antithrombotic therapy? Do you think that we will get better at integrating all of these findings, both from a biomarker research perspective, but also eventually, like even in the clinic? So I know not the easiest question to answer, but just wondering your thoughts on that.
I know it was one of the key questions of the paper that you've been working on. So I think you also gave the answer, Joseph, in a way. I think preferably we should integrate all our efforts and knowledge and skills in going forward. And that's the problem, that now drugs are being developed and tested and rapidly in clinical trials and so on. And then we run after them with our biomarker stuff. And so I would really like to see this better integrated in order to make more structure advance in moving towards personalized medicine. And I think it becomes more and more important that to be aware that the large studies will not give the definitive answers. And I hate it when large studies that are negative kill a potentially good concept. So we should really try to prevent it. And I have experienced that in the past with the studies on sepsis that I mentioned initially. Then we also thought that, well, if you would infuse TFPI or antithrombin or activated protein C, you would reduce mortality. And we severely underestimated the patient heterogeneity. And we attempt to make the same mistakes now with studies in stroke patients or myocardial infarction. We think it's one type of patient and that we can figure out anything afterwards, looking at, adjusting for baseline characteristics and risk factors, etc. But it's not as simple as that. And that's why we really should go back to the basis and talk with each other and decide what do we need to learn about these differences in different types of patients, different males and females, but young and old, and how can it help us to develop or to design, or not so much design the proper drugs, but design the proper, think about the proper indications for the right patients.
Perfect. Yeah. And it's like you mentioned, sometimes if you look at things, you have your nose to the grindstone and you're looking at each of these individual studies, it can be a bit depressing. But if you take a step back and you look where we stand now compared to 50, 60 years ago, and even 100 years ago, there's progress there. So sometimes I think it's important to do that. But so with that, we're at the 1 hour mark. So I will just say thank you very much again, Dr. Tinkate, for this really fantastic presentation. And just a friendly reminder that the recordings are available at the link here. Please complete the seminar evaluation that's available via email. And just to let you know that our next seminar is already scheduled for January 8th. This is going to be Dr. Yan Xu and Shobha Dawson presenting on shining a spotlight on invisible minority groups, incorporating EDI and VT research design and implementation. So once again, thank you, Dr. Tinkate, for this really great presentation.
Thank you, Joseph, for moderating.
No problem at all. Thank you.
Bye.